Welcome to this explainer. Today, we're diving straight into the pathophysiology of the three most common over-the-counter analgesics, pulling directly from the medical literature to really understand how everyday medications can completely hijack the human body.
Now, it really begs the question, right? How can these seemingly harmless, everyday remedies become fatal? Well, the literature makes it abundantly clear that the line between a therapeutic cure and a systemic threat is incredibly fine. We take these pills to lower fevers, stop headaches, and soothe sore muscles, but when you look at it on a molecular level, the margin for error is actually startlingly narrow.
Okay, let's take a quick look at our roadmap for today. 1. The medicine cabinet threat. 2. Acetaminophen, the liver's limit. 3. NAC, the glutathione substitute. 4. Salicylates, the acid-base battle. 5. Bicarbonate, the ion trapper. And finally, 6. NSAIDs, the antidote-free outlier.
Section 1. The medicine cabinet threat. Identifying the household culprits.
All right, acetaminophen, salicylates, and nonsteroidal anti-inflammatory drugs, or NSAIDs. These three distinct medication classes are literally sitting in almost every home right now. And while they all serve the primary purpose of treating pain and reducing fevers, their underlying metabolic pathways are completely different. When a patient crosses that threshold into an overdose scenario, the mechanism of toxicity is entirely unique for each class. Acetaminophen metabolism overwhelmingly targets and just overwhelms the liver. Salicylates, they wage this chaotic, systemic acid-base battle right in the bloodstream. And NSAIDs trigger widespread multi-organ failure by basically shutting down protective enzyme pathways. Understanding these distinct, specific pathways is absolutely the key to counteracting their toxicities.
Moving on to Section 2. Acetaminophen, the liver's limit. The ticking clock of APAP toxicity. So, acetaminophen toxicity isn't this immediate, cinematic crash you might expect. Instead, the literature describes it as more of a slow, deceptive ticking clock toward total liver failure. During the first 24 hours, the gastrointestinal phase presents with relatively non-specific symptoms, just nausea and vomiting. But the true danger really reveals itself in stage 2, between 24 to 72 hours. Patients very often experience a false clinical recovery. Their GI symptoms fade away because the initial insult is over, leading them to believe the worst is past. But under the surface, hepatic necrosis is silently beginning. As those hepatocytes die off, liver enzymes like AST and ALT leak out and absolutely skyrocket in the bloodstream. By stage 3, that massive cell death triggers profound hepatic failure and severe metabolic acidosis. Without intervention, stage 4 ends in either a very slow resolution of that hepatotoxicity or death.
Section 3. NAC, the glutathione substitute. Restocking the liver's defenses.
To really understand why the liver fails here, we need to zoom in on the cytochrome P450 pathway, specifically the CYP2E1 enzyme. Now, acetaminophen is mostly metabolized safely through glucuronidation and sulfation, but a tiny fraction goes through CYP2E1, and that creates a highly reactive toxic byproduct called NAPQ. Under normal circumstances, your body's native glutathione stores neutralize NAPQ with no problem. In an overdose, however, those primary pathways are totally saturated. CYP2E1 shifts into overdrive, and glutathione is rapidly depleted. That unbound NAPQ is then free to bind to hepatic macromolecules, causing rapid cell death. So what's our countermeasure? N-acetylcysteine, or NAC. NAC acts as a glutathione precursor and a direct sulfhydryl group donor. It essentially swoops in to bind and neutralize that toxic NAPQ, completely restoring the liver's natural defenses. If we can administer it within 8 hours of ingestion, it is remarkably effective at preventing severe hepatotoxicity.
To actually deliver this molecular rescue, emergency departments rely on a really strict 21-hour IV protocol based entirely on the patient's weight. And the rationale for this tiered approach is all about pharmacokinetics. We start with a massive loading dose, 150 milligrams per kilogram over the first hour. This rapid influx is specifically designed to immediately saturate those enzymatic pathways and just halt any further NAPQI-induced damage before more hepatocytes die. Following that initial stabilization, 2 successive maintenance doses are given over the next 20 hours. This prolonged exposure ensures a steady, continuous supply of sulfhydryl donors, giving the liver the sustained support it absolutely needs to completely clear the remaining toxins and begin cellular repair.
All right, let's jump to Section 4, the salicylates, the acid-base battle, the dangers of aspirin overdose.
So, aspirin, a primary salicylate, creates this wild internal acid-base tug-of-war. First off, salicylates directly stimulate the respiratory center in the medulla of the brain. This physically forces the patient to hyperventilate, blowing off massive amounts of carbon dioxide and creating a primary respiratory alkalosis. But simultaneously, at the cellular level, salicylates uncouple oxidative phosphorylation. Basically, the body's cellular machinery starts running in absolute overdrive without actually producing ATP. The result is a massive generation of heat, which often presents as a severe fever, along with a dangerous buildup of lactic and keto acids as byproducts, driving a profound metabolic acidosis. Because these two totally opposing forces are happening concurrently, a patient's blood pH might superficially appear normal early on. But that is a really dangerous illusion. The body is expending massive physiological energy just to maintain that balance, and respiratory fatigue can lead to a rapid, fatal crash.
Section 5. Bicarbonate, the ion trapper. Flushing the toxin away.
Treating this specific toxicity is incredibly fascinating because it requires manipulating the chemistry through a process known as ion trapping. Salicylates are weak acids. When they're in an uncharged, non-ionized state, they can easily slip right across lipid cell membranes, penetrating deep into the central nervous system to cause severe neurotoxicity. However, by administering IV sodium bicarbonate, clinicians actively alkalinize the patient's blood and urine. Shifting that pH gradient between the tissues and the blood forces the weak salicylic acid to give up a proton. It becomes charged or ionized. And because charged molecules physically cannot pass back through those lipid membranes, the salicylates get pulled out of the tissues, into the blood, and are ultimately trapped right in the renal tubules. From there, they can be safely excreted without being reabsorbed.
Now, for this ion trap to function optimally, our clinical target is to carefully push the patient's urinary pH up into the highly alkaline range of 7.5 to 8.5. But, and this is a big but, this procedure is an absolute tightrope walk for the toxicologist. Pushing the blood pH too high can trigger severe hypokalemia, where serum potassium drops to incredibly dangerous levels. That drop can rapidly worsen the patient's neurological status and cause cardiac arrhythmias. So continuous hypervigilant monitoring of both urine and blood chemistry is absolutely mandatory to ensure the kidneys can excrete the maximum amount of trapped salicylates without throwing the patient's entire electrolyte balance into a fatal spiral.
Finally, Section 6. NSAIDs, the antidote-free outlier, a terrifying narrative twist.
NSAIDs, so things like ibuprofen and naproxen, introduce a completely different physiological crisis altogether. The toxicity here relies heavily on the severe inhibition of the COX-1 and COX-2 enzymes. Under normal conditions, these cyclooxygenase enzymes are busy synthesizing protective prostaglandins. Those are the lipids that maintain the thick mucosal lining of the stomach and ensure adequate renal blood flow. But in a massive NSAID overdose, often exceeding 400 milligrams per kilogram, this synthesis is just completely shut down. Without those protective prostaglandins, the gastric mucosa rapidly ulcerates, leading to severe gastrointestinal bleeding. And simultaneously, the loss of vasodilatory prostaglandins in the kidneys causes renal blood flow to just plummet, precipitating acute renal failure. This toxicity isn't localized at all. It cascades across multiple systems, inducing central nervous system seizures and dangerous cardiovascular collapse.
And here's the really terrifying twist. Unlike acetaminophen, where the liver is rescued by NAC, or salicylates, where we can brilliantly utilize that sodium bicarbonate ion trap, a massive NSAID overdose has absolutely no specific pharmacological countermeasure. There is no molecular antidote coming to save the day. Down in the intensive care unit, medical teams must rely entirely on aggressive supportive care. We're talking continuous IV fluids to maintain renal perfusion, utilizing antiemetics, actively managing those seizures with benzodiazepines, and carefully monitoring the respiratory drive. The medical team's primary role is to synthetically sustain the patient's organ functions, just hoping the body can metabolize and clear the drug before that systemic damage becomes permanent.
These everyday analgesics are absolutely marvels of modern pharmacology, for sure, but their toxic potential reminds us of a fundamental medical truth. The dose makes the poison. The exact pathways that offer us so much relief are the very same pathways that, when overwhelmed, lead to profound systemic failure. The science behind both the toxicity and the antidotes is a true testament to the incredible precision required in pharmacology. So I'll leave you with this. Next time you open that cabinet to grab a quick fix for a headache, will you reconsider the delicate, incredible power of the chemistry sitting right there on the shelf?